the IVUS showed us was there was a decent landing zone in the mid RCA, just proximal to the stented segment, previously stented segment. So what we did was we dilated the PDA ostium with a 2x12 NC balloon, and the distal RCA to the mid RCA was dilated with a 3x13 scoring balloon at high pressures. So this was the result after the pre-dilatation, and then we had the linear stent in place. So we stented the PDA to the distal RCA with a 2.5x28 linear pearl. So you can see the balloon marker and stent markers clearly here. So this helps us to precisely position the stent, and then after this, we did a overlapping stenting with a second 3x44 linear from the mid RCA, overlapping with the distal stent. And then we did the distal PDA was post-dilated with the distal RCA was dilated with 3x10 NC, and mid RCA was dilated with a 3.5x10 NC at high pressures. So this is the final result of the RCA. So the stent, you can see that it was a really tortuous initial proximal part, but we had no difficulty in tracking down the stent, and the markers, you can see the distal overlapping segment, the two markers of the stents help us to have a good overlap or adequate overlap, and we can be very clear about the overlap without having to take a stent boost repeatedly. So this was the advantage which I felt while using the stent. So here you can see the markers. And now moving on to the second case, a 65-year-old gentleman. He came with acute anterior wall MI. So we did a primary PCI to the LAD, and the RC had a 80% lesion proximally, quite a diffuse disease in the proximal part. So this was the LAD which we tackled on the first day, and the LAD RCA, you can see a lesion in the proximal part, and then we have a relatively normal segment in the mid RCA. So the RCA was prepared, the bed was prepared, and we used a 3.5x44 linear pearl, and we positioned it, and then it was deployed, and it was optimized with a 3.5x10 NC with a good result. So in this case, actually, there was not a very good guide support. Even without the good guide support, we could track a long stent, which is quite remarkable. Unlike the usual stents where we find some difficulty while tracking long devices in the right coronary artery, here the trackability was excellent, and the case went off very well. So this is the final result. So now moving to the third case, a 40-year-old doctor is an obese guy with a dyslipidemia. He's a reformed smoker. He stopped about 3 or 4 years back. Now he had a history of dyspnea on exertion, which he attributed to his overweight. So he was found to have a TMT positivity on a routine pre-insurance checkup. And after that, he was advised CAG. The angiogram shows proximal to mid RCA 80% lesion. Quite a long lesion. We have a relatively good segment in the distal RCA, and with two good septal branches coming in between. So the bed was prepared, and we placed 275x44 linear pearl, and stent was deployed, and then we did a proximal optimization with a 3.25x6 balloon, and the a lady was then post-dilated with a 3x15 balloon. And this was the result we got. So from my limited experience, what I have felt that it's an excellent stent with a good trackability and the utility. What I find most useful is especially while you do a overlapping stent, you can precisely do the overlapping without taking much stent boost or stent enhancements. And this is my limited experience. Thank you all.
So thank you so much, Dr. G.K. Praveen. That was a wonderful case presentation. So we have our moderator for the day, Dr. Amit Chaurasia. Sir, would you like to give your insights?
Good evening. I'm sorry for the delay. I'm still in the lab working.
No issues, sir. No issues.
So it's all the three cases were excellent, and we could see that the stent had a great trackability, and even overlapping was really good. So, and Dr. Praveen, these three cases, how long it has been, like how before you did these cases?
No, just maybe the one case was within the last 2 months, because we had the stent only since the last 2 months. So it's not a very long back. So the long-term results, we don't have any long-term results. But hopefully with the data we have and because unless we have a good data, we don't usually get FDA approval. So hopefully we think that everything will be fine in the long term. But acute results, the use maneuverability, trackability, and all those things were really wonderful with this stent.
Yeah, so I think there is a the stent edge. There is a tracker kind of thing which allows it to pass through zip through the tortuous segment, and even I've used in some cases where there is a calcium edge and other stents were not tracking, the stent edge would be hitting that and would not pass through. But with this, I think that's a very intelligent innovation on this stent tip.
There was already a stent in the tortuous RCA, but usually we try to use the conventional stents. It hit the edges of the first stent.
Yes, so edge, it can negotiate the edge or the calcific this thing. So if you need to take any stent within a previous stent, or especially in the overlapping, if you want, this will be easier to track. So if that stent, other stents are not tracking, it is worth trying this one.
Okay. I think it was a great presentation. So I think we should move to the next presenter.
Okay, thank you so much.
So we will go with Mr. Uri's presentation, as Dr. G.K. Praveen had some urgencies, so we have to take his session first. So Dr. Amit, we can go for Uri's presentation now.
Okay.
Can you hear me?
Yeah, clear.
And can you see my
yes, we can see
this. Of course. Yeah.
Wonderful. Thank you. So first, thank you very much, everybody, for having me today. It's a pleasure to join you. I want to start with a linear presentation. First, I will start by actually by presenting a little bit of the Medinol group. So the Medinol group has been since 1992 in the market. We have actually the Medinol company and two sister companies. The Medinol company is responsible for stenting and catheterization, whereas we have one sister company called Valve Medical that is designing today a TAVI that eventually now works on 12 French and hopefully will reach 9 French. So it's still under R&D. And we have Microtech Medical that is working on designing micro sensors that can be attached to different implants. I think Medinol became very famous worldwide when we first introduced our near bare metal stent. It was an innovative bare metal stent that actually had two innovations. One, it was the first coronary stent that was longer than 15 millimeters. And second, it had the optimization between flexibility and radial strength, providing the right flexibility and scaffolding. With that, Medinol has become market leader in Europe and the US and had 25 studies with more than 5,000 patients. Actually, the first stent was implemented in 1995 in Milan by Professor Colombo. He liked it so much that he actually implanted 2 stents in the first case. Since then, we obviously continued to innovate, and today we're introducing the 7th generation of our drug-eluting stent, the Elunier Pearl, which I'm going to discuss more in detail today. So to start with, the Elunier Pearl has different components. So the bare metal stent is a balloon expendable cobalt chromium L605. The drug that we use is ridaforolimus. It's called ridaforolimus. It's a limus analog. And we have a unique coating, which we call an elastomeric coating, that blends actually 2 components, the carboxyl and the PBMA that is used in other stents as well. First, I would like to talk about our unique design. So we're the only stent in the market that has a unique design that has alternating strut thickness. So we actually have one strut that is 40 microns that is responsible for the flexibility and conformability of the stent, whereas the other strut is 72 microns that is providing the radial strength. The combination in a closed cell design provides the optimization, bringing a stent that can actually be delivered easily to the target lesion, and once deployed, can conform to the vessel wall, as we saw just now in the RCA that was presented, that shows very nice result of conformability as well. This design actually showed as well that we have the lowest metal to artery ratio. This is, let's say, one of the only checks that, all the companies have to adhere in the same manner, because it's a regulatory requirement by the FDA. And hence, basically what we're showing here is that our stent has the lowest surface area that touches the vessel wall. This allows for fast endothelialization as well. In terms of our manufacturing, we have a unique manufacturing process. We are the only stent that actually is being produced on a flat panel. We use CNC devices we can cut on one flat panel up to 500 stents. And then once the stents are cut, we actually have automated big chunks of our manufacturing process, such as the automated visual inspection of the stent panels. This increases significantly our manufacturing quality, because we're checking every stent, not by humans, but by computers, to make sure that all the struts are properly cut, and if there are any issues with the cutting of the struts, they are discarded even before we continue. Eventually, it influences as well the way that we are coating our flat panels, because we have a much more uniform way to coat our stents, both with our polymer that holds the ridaforolimus drug as well. So talking about our coating, as I mentioned, we have an elastomeric coating that is a durable coating made out of carboxyl and PBMA. The carboxyl is responsible for the elastomeric essence of the polymer, and the PBMA is responsible for the drug elution, holding the drug. The result is that you may see in the pictures, even in crimped nominal pressure or rate burst pressure, there's no tearing of this polymer. It actually may expand to up to 400% of its size without tearing. This provides as well a very uniform drug elution, to the vessel wall. So now concentrated a little bit about the innovation of the Elunier Pearl. We have introduced with the Elunier Pearl 2 innovations. One is that we have changed the spring metal tip to a hybrid spring metal tip that has a low tip entry profile. And we've coated it, the metal spring tip, with a nylon jacket that reduces friction with the vessel wall. And we've changed the metal in order to increase the radiopacity. In addition, we have added RadioPAC markers that I will show now in the following slides. So our spring metal tip actually has these 4 components. It has unparalleled durability because it's from metal. Second, it has a design for flexibility and agility. So even though it's made out of metal, when compared to other tips and pushed one against the other nylon tips, surprisingly, it's much more flexible than most of the tips in the market. Then you have an enhanced courseability and pushability. And lastly, it's the only tip in the market that can actually be seen under angio. One of the nice features that we have is that we have eliminated the fish mouth effect that concerns many physicians in the market. With regards to our RadioPAC markers, the need from the physicians during, let's say, the last decade was to reduce the strut thickness. Reducing the strut thickness made that the stent became less visible under angio. And hence, we understood that we need to add the RadioPAC markers in order to increase the visibility. So what we did, we added 2 RadioPAC markers in the distal and proximal ends of the stent, and we placed them in 90 degrees angulation. The 90 degrees is there in order to make sure that no matter the C-arm angulation, you will at least see one of the markers. Here is an example where you can see actually the 4 markers in the distal and proximal ends of the stent. So moving quickly to our clinical update, here is the TLF of our pooled Bionics and Nereus clinical trials. These 2 clinical trials have combined for about 1,000 patients in each arm. They were regulatory aimed to pass both the FDA and the CE marking. So as you can see, at 24 months, we have the pooled data shows no significant difference between the Elunier and the Resolute. Moving to the safety profile with definite and probable stent thrombosis at 2 years. Again, this obviously was not covered by the study, but directionally you can see that there is no major difference or even slight favorable results to the Elunier, especially in the late and very late stages. We conducted as well an HBR study where we took the design of the Onyx 1 and the Leaders 3. You can see that the primary endpoint, that was cardiac death, MI, and stent thrombosis, was very low at 4.9%. And the secondary endpoint, which was the actual bleeding of BARC 3 and 5, showed remarkable, very low results. So to summarize my presentation, I would like to emphasize again that we have a unique stent design, which we call Y-cell, where we have alternated strut thickness. We have excellent conformability, uniform scaffolding and vessel support, and optimal drug release because of this conformability. Our elastomeric polymer is a durable polymer that is releasing ridaforolimus, which is a limus drug. And again, it's very unique because it has these 400% stretching capabilities to its size. With regards to our delivery system, we have really excellent delivery system with a unique metal spring tip that now is coated with a nylon jacket, again, to reduce the friction and to enable you to pass through calcified lesions. And we added the RadioPAC markers on the stent, and as was presented, it's very usable, especially when there's overlapping of stents. In terms of the outcomes of the clinical trials, we present 7% TLF at 24 months and 0.1% extremely low rates of late and very late stent thrombosis at 24 months. With that, I would like to thank you very much for your time.
Thank you, Doctor. So that was a very comprehensive overview, and it was very, so it stands out at a different kind of drug-eluting stent, which has deliverability plus the RT to metal ratio is quite favorable, and the 24 months data is also quite impressive. I believe it is FDA approved also, so that makes even more acceptable for international market.
Yeah.
Amit, any comment?
I feel it is an excellent stent, particularly looking at that nitinol that is on the top of the balloon. Trackability should really be good, and I have not used it until now, but it will be good to use this stent and see how it goes.
Well, I
Dr.
hope you'll
Manohar?
have good feedback.
So we
No,
have
it's-
Dr. Manohar also, if he wanted to. Sorry to intervene. Sorry.
Okay,
You
so
were saying something, sir?
So looking at the stent struts and everything, I feel that the eosinophilic reaction and everything is going to be less. I don't know how much the alternating strut thickness is going to matter in this case, but definitely it will be good to look at really long-term data. But 24-month data looks really promising in this case. Dr. Manoharan, you would like to add something to the discussion?
It's a good stent. It's only available for the past 1 month in my center. I used it for more than 10 cases. It's a small vessels and calcified lesions is easily trackable, and the marker is very useful. It reduces the radiation dose also to the patient as well as the operator. How it is doing these things? After my presentation, you will understand what are the advantages of this stent comparative to other stents. We'll wait and see. But imaging, I have not did this for this patient. In future course, I want to do the imaging for these patients. In my presentation, you will see it.
So I just want to ask one thing. What about the radial strength you are telling it's all closed cell design or open cell design followed by closed cell design in some places?
Which this stent or you want?
This stent.
Yeah, this is a open type one.
But he told it was a closed cell design in his presentation. That is why
here it's not like other closed cell type.
Okay. Because if it is a closed cell design, then doing a bifurcation is going to be really tough because...
bifurcation, it will be useful. It's one part is 42 mm micrometer, another part is 72 mm. So the flexibility is more. Whenever you are kept in these bifurcation areas, it will be opened, the cell will be opened easily. That is the advantage of this type of thing.
Okay, I think we should move on to the next presentation. So I think it is...
will be useful.
The next presentation is of Dr. Viveka.
Yeah, so I'll share my presentation. Yeah.
Yes, sure, sir.
So can you see the slides?
Perfectly.
Yes, sir. Yes, your slides are visible.
Yeah, so going into the full slide mode. Yeah, so this is I'll present a few cases where the This is the first case, which is a 65-year-old gentleman, had coronary artery disease, diabetic, hypertensive, had acute coronary syndrome, ST elevation, myocardial infarction, and had dyspnea, severe LV dysfunction, ejection fraction was low, and had previous stenting to LED, OM, and RCA in 2019, then 2020, and 2021. He was a drug defaulter also. So general condition was sick, so had tension was conscious, had sugar was also high. You can see the random sugar was 444. Has tachycardia, heart rate was 123, blood pressure was okay, 137/70. Oxygen saturation was 99%, and so the coronary angiogram, it was a single vessel disease. So primary PTC stent to LED was done using the
Is everything okay, sir?
yeah. So I think just my presentation disappeared. I'll just yeah. So
It is visible to us, though.
so slide is just not moving.
So you can
Doing this.
unshare and reshare, then it will.
I think we'll have to redo this. Yeah.
Yes, yes, yes.
Yeah. Can you see now?
Yes, sir, it is visible now.
I think your slides is not moving.
Yeah. So I think we have done some. Yeah. So this is the angiogram was there. So you can see the patients. So here we had done the pre-dilatation. I think by mistake they have written instead of LCX, they have written LED. So post imaging, it was, you can see this is the very important and useful piece of this stent. So in this circumflex, we had stented, and here you can see because of the two markers proximally and to distally, the post dilatation is very good. So even in a shorter stent, sometimes people go out of the stent and post dilatation can induce some dissection, but being the good robust marker, this will be fine. So this is the patient who had a very good result with the L-Need Pearl stent in the circumflex. So I think as the characteristic of this stent is concerned is which we had already shared about the good things about this stent is that the trackability in this tortuous segment, and if there is a calcific spur that will go quite easily. The second thing is that it is long-term outcome will also be good, as the URI has shown that the 2 years data is good, and apart from the trackability and all, it is, somebody asked about the side branch access. So this is something where the middle cell is, the strut is smaller or thinner. So you can have a good post dilatation, also side branch access, you can do well, and trackability of stent through the stent will also be reasonably good. So in fact, I'm out of station, so I did not bring the cases. So this is what I got on the mail. So in short, this is a case presentation which I just wanted to show. So over to the chairpersons. I'll stop sharing.
Thank you, Dr. Bevekar. That was an excellent presentation, and I think you have clearly demonstrated that this stent, one of the beauty of this stent is in overlapping segment, We have Dr. Praveen as a panelist.
Yes.
Dr. Praveen, your opinion, please. What do you feel like there are multiple markers on this stent? So will this interfere with the stent boost that we take?
I think it will. It is easy to visualize the stent, and Dr. Viveka has shown, how it will help in post dilatation and avoiding age dissections. Good for osteal thing where we majority of time struggle for exact putting of a stent. Though osteal stent is always difficult, but yes, this marker would help. And I remember the old stent. Ones which was with marker sometime we have seen was Janus, I believe, which is no more available, and it was good to post dilate and put the stent, or you can say exact positioning. It would help.
Okay, so that's an excellent point you brought out. Dr. Kesar, what do you feel about the visibility and trackability?
I have a limited experience. I think it's very suitable for osteal lesion, as already been told. Otherwise, I think other parameter characteristics and not too much, because we used only for a couple of steps.
Okay. So you feel that just like Giants, which has the stent, distal stent, just in the marker of the balloon, this stent, since it has a marker, the osteal placement will be excellent.
Excellent.
Of course,
That
that's going to be the case in this case.
Yeah.
So that's an excellent point for this stent, as we know that osteal stent placement is always a challenge. And as you brought out, I think this will be really helpful in this in the patients who have osteal lesions. Okay, I think we move on to the next presentation. The next presentation, I think, will be by Dr. Manohar.
Yes. Good evening to all. My assistant Dr. Sundaresan will present the case now. After that, I will join with your discussion. Sundaresan, please share the screen.
Yes, sir. Sir, am I audible and is my screen visible, sir?
Yes, it is visible.
You are audible and visible. Yeah.
Yes. Yes. Thank you, sir. Yes, sir. I thank Professor Dr. Manohar, sir, for allowing me to present this. Sir is a head of the department in MGM Healthcare. So we had this stent for the past 1 month in our center, and this is our experience with the Elinor Pearl drug-eluting stent. And I'm just going through a series of cases that has been dealt in our hospital. First is a 50-year-old female who is a diabetic and hypertensive who presented with acute onset chest pain. ECG showed evidence of ischemia in the anterior wall with regional wall motion abnormality in the LAD territory with an adequate LV function. So we did an angiogram which showed a significant lesion in the right coronary artery and in the LAD as well. So we decided stenting of both LAD and RCA. So first we wired LAD, and then it was pre-dilated with a 2.512 balloon, and the mid-LAD segment was stented with a 2.7548 drug-eluting stent. And then we proceeded with stenting of the proximal LAD with 322 drug-eluting stent, which was placed in the osteoproximal segment. And we eventually post-dilated it with a 3.58 mm balloon. So after post-dilatation, these were the post-dilatation, and after post-dilatation, this was the final result of LAD. And then RCA was planned electively at a later stage. So next, going with a second case, it was a 53-year-old male who was a smoker, hypertensive, who already had an inferior volume in 2014 and had a primary PCA to RCA done. Now presented to us with 1 month duration of exertional angina and OPD, and ECG showed with less than 1 mm elevation in lead 3 and ST depression in 1 AVL, and echocardiography was normal LV function, and we did a coronary angiogram for this patient, and the angiogram revealed a significant disease in the LCX territory, and LAD as well. And the RCA stent, which was placed in 2014, was patent. So next, we decided to stent LAD first, followed by LCX. So LAD was crossed with the wire, and the direct stenting of LAD was done with a 333 drug-eluting stent, as you can see here. And next, we post-dilated the LAD stent with a 3.58 mm balloon. And after that, we decided stenting of the LCX with a 3.544 mm drug-eluting stent. And again, we required a stenting from the osteoproximal LCX. And here we used a 3.544 alluvial pearl drug-eluting stent. And then we post-dilated with a 3.758 mm balloon. And after post-dilatation, these were our final angiographic results, which were fairly adequate in both LAD and LCX. And next, moving on to a third case, which is a 51-year-old male who's a diabetic smoker and dyslipidemia, who presented with chest pain for 2 hours. Patient is an old patient is a chronic stable angina who already had a stent to LAD in 2019. Now ECG showed is significant ischemic changes with the regional wall motion abnormality in echocardiography with an LV function of 42%. Troponin was positive. So we immediately took for a coronary angiogram, which revealed a significant lesion in a critical lesion in the LAD with a slow flow and a completely occluded LCX. As you can see, the LAD is slow flow with almost TIMI 1 flow. And there is a stent in the mid LAD segment. And the right coronary artery had minimal disease, so we planned for a medical management. So we decided to go ahead with stenting of LAD and opening of LCX. So we wired both LAD and LCX. And since LCX was occluded, we first pre-dilated with a 2.8 balloon. And after flow was established, we did a stenting of the osteoproximal LCX with a drug-eluting stent. And we post-dilated it with 312 balloon. And next, this was a check angiogram after stenting of the LCX. And next, we decided stenting of the LAD with a direct stent. And we can see we have used 3.538 drug-eluting stent. And this was after deploying the stent. And we post-dilated the stent. And we have placed the stent overlapping with the previous stent, which was already placed in the mid LAD segment. And these are our final results of both LAD and LCX, which was stented. And moving on to a fourth case, this is a case which was done today. A patient presented with is a 50-year-old male or known diabetic, presented with chest pain for 2 weeks duration. Again, ECG was showed ST depression with T inversion and inferior leads, but there was no RWMA, and ejection fraction was 62. And angiogram showed a single vessel disease of LAD, and there was an anomalous RCA with the high posterior origin. So RCA was engaged with the JR guide, and it was wired with the BMW guide wire. And the osteoproximal segment of RCA was stented with a 333 alluvial per drug-eluting stent. And this was the stent was deployed, and it was later post-dilated with a 3.58 balloon. And these were our final angiographic results, which were fairly normal with no complications. So the advantages of the alluvial pearl drug-eluting stents that we have observed so far in this 1 month was that the markers at the stent edges are great advantages. The two, as it was mentioned in the previous speaker, it was two markers are oriented at 90 degrees angle. So at whatever position of the C-arm, we were able to identify both the markers, and there was no overlapping. And there was a low radiation dose exposure, as it reduced, the cine images were reduced. So there is a low radiation dose both to the patient and the operator as well. And we avoided using contrast frequently to check the stent position. And if you notice, in all the cases, we used this alluvial per drug-eluting stent for osteal lesions. So the markers in the ostium would minimize the geographical miss, which is one common complication of osteal lesion. And of course, the long-term outcomes of this stent are yet to be studied. So this was our experience with this alluvial pearl stent. And yes, thank you, sir. Dr. Manohar sir would elaborate on this.
Thank you, Sundaresan. This, hello, I'm able to audible?
Yes, sir, you're audible, sir.
Yes, sir, you're audible. Yes.
We all cases we did for osteal lesions. One is LAD and LCX osteal, and another is RC osteal, and another is proximal to the RCA, and two LCX lesions. One is calcium containing and tortuous vessels. We used this Elunier stents. The advantage in LAD osteal placement is perfect. We can analyze with two views. One is caudal and another view is epicranial. So the 90-degree marker presentation is useful to which is the location of ostium, and perfectly we can able to put it in ostium. There is in angiographically, I am unable to see any geographic miss in the LAD. As well as in LCX, one is 60-degree angulation, another one is 90-degree angulation. In this patient, it's a tortuous vessel LCX. In that, it's a long stent, Elunier long stent is placed from the ostium to the mid part of the LCX. That is, in the placement of ostium is excellent because of this marker, and the stent studs are fully open. And as well as in this, in RCA also, I able to appreciate the ostium with this Elunier marker, and because I put the wire in RCA sinus also one wire, so placement is perfect. In all cases, without stent enhancement or stent booster, I dilated, post dilated with 1:1.25 balloon sizes. Suppose I uses 3 stents in LCX means I used it 3.25 to 3.5 mm NC balloon post dilated within the marker. So I avoided the that is stent enhancement and radio zoom. That is stent booster. So the radiation dose to the patient as well as the operator is reduced. Is it in future the imaging may be overlooked by these stent markers, marker stents in future? I don't know. It may be. Suppose if we perfectly select the size of the stent according to the vessel size, after that there is no need for imaging. It may be useful. This is my observation in with these stents. In future studies, if I added the imaging, OCT as well as IVS, how it will be useful for this placement of the stent in future course, I will decide it. Thank you. Any comments from the chairpersons as well as audience?
Thank you so much, sir. It was an excellent presentation, and you showed a lot of varieties of cases. So, Dr. Vasavraj, this stent, I could see the shaft of the balloon is not as big as the other stent balloon. So do you think this will be advantage in ostial placement where, sometimes if the shaft is larger, it closes up the other side vessel?
Hello?
Hello? Yeah.
Pardon, sir. So I didn't get your question, sir.
I could see when Dr. Manoharan was placing the stent, when he was
Yes, sir.
inflating the stent, the shaft was not so large. So none of the cases, actually, the side branch got affected while it was there. So do you think this will be a great advantage in comparison to other stents that is available at present day?
Could be, sir. We need to see more. We need to have more data, more patients to exactly conclude that it will be really beneficial with respect to protection of side branch and all. So definitely it's a good stent for ostial placement. But one concern, and also if you want to precisely place between to avoid one of the side branch, then also you get a clear idea to avoid a side placing right in front of the side branch ostium. That is one more advantage, especially when there is a circumflex with multiple OMs. One only concern with this stent, what I feel is not the is just a cosmetic. That is, when you're doing multiple overlap stents, you will have multiple markers at the overlap point, and they are not in a particular order. So it looks little bit ugly. Otherwise, it's an excellent stunt, and it will definitely help us in precise positioning, be it in ostial or in bifurcation lesions where you don't want to commit to two stent strategies.
Okay. Excellent. So, Dr. Satish, would you like to add something more to this intuitive design that they have come up with? Dr. Satish, are you there? I suppose he's not there. So let me put the same question to Dr. Sunil if he is there. Okay, I think both are not there. So, Dr. Manoharan, would you like to add something more? Because I can see that you have done in multiple cases, so you'll be having the maximum experience. So
Yes,
it will be good to learn from your experience.
yes,
So
because of this marker, one case in diagonal branch, I saved the ostium of the diagonal. I put the stent in the middle AD. The marker is exactly placed at the level of lower part of the ostium of diagonal and deployed it. So the diagonal ostium is preserved. So that is one advantage. So we can easily identify this diagonal. I did it in the epicranial as well as iliocranial. I identified this diagonal ostium, then I put the stent there. And also in another case, I put the wire in PDA. And I put the stent in PLB. It's a super dominant ostia, PLB, with this short stents, Elunius short stent. It will be also useful. So we can avoid, with this marker, we can avoid this side branch closure or other things. But I am not yet used for these bifurcation lesions. I must try it for also.
that is what I saw, that all the speakers until now have not used for bifurcation lesions. So it will be good to see. So, okay, I just wanted to know, what is the strut size in comparison to Resolute Onyx or this Giants Prime or Expedition or...
Yeah, that's good questions. So in left main, this stent expansion is little bit less actually. If you take this 2.5 stent, it will be actually they given it's 0.75 to be expanded, but it is not true. It will expand up to 0.25 to 2.3. That's all in my experiences. And the 3 or 3.5 stents expanded to 0.4 only. It is not expanded more than that. But Onyx will expand at 1.5. Expansion will be present in more than 3 diameters. That is useful in because if you are using 3 size stent, if you are using NC balloon 3.5 or 4, if the vessel size is 4, but this will not be perfect for this stent. But Onyx, it will be fully expanded. That will be opposition good. That is the one problem with this stent.
And
the expansion is a little bit difficult here.
The strut size, the side dimension of the strut, I think it looks quite large enough. So side vessel closure will be lesser in this stent. You feel so?
Here, the vessel closure is, I'm not experiencing anything, but side branch vessel closure may not, in this stent struts, it's if they see this W shape, okay, one part will be the stent struts is less, and another part is stent struts is more. Because of that, the expansion will be good. It should be good, but we must see it in OCT or IVUS.
Okay. I think that all the cases were good and excellent presentation. So we move on to the next presentation.
Dr. Anish Jain. Yeah.
Dr. Anish Jain.
Thank you.
Hi, good evening. I'll just start sharing my slide. Am I audible and my slide visible?
Yes, sir. Yes. You're audible and your screen is visible.
Good evening, everyone. I'm Dr. Anish Jain from Ruby Hall Clinic, Pune. So the thing which caught my attention while when this new stent came in the market was first its features. It was a cobalt chromium stent. It had a newer molecule, ridaforolimus, with a very good data to back it up to show that the long-term ISR rates were very less. And one more thing which again caught my attention was its hybrid spring tip, so which had a very low tip of entry profile, and the trackability has improved because of this spring tip marker. And obviously, as everyone has mentioned about its radio opaque markers, that has definitely improved in placement of the stent and reducing the radiation dose overall, as well as in ostial placement of stents. So because it was a newer stent and it was available just a month ago in our center, so I started using it in simpler lesions. And this was one of the first cases. This patient had presented as an inferior wall MI, was thrombolized elsewhere, had a simple type A lesion in the mid RCA. So we balloon dilated it and we placed a long 3 by 44 stent, Alumir Pearl stent. The stent tracked well and it expanded also. And after post dilatation, we had a very good result. The second case was of an elderly gentleman, 70-year-old, had presented to us with inferior wall MI. You can see the OM is not flowing in this slide. So we wired it, and after wiring, some amount of flow was restored, and you can see on the right panel that the patient has a very high thrombus load. So we did a couple of runs of thrombosuction, and then we placed in the stent. Even after thrombosuction, the thrombus load was quite high, and given that the patient had a LCX to OM lesion and needed a long stent, it is always tricky to park a long stent, especially in an LCX, especially during an emergency. But this stent tracked well. We had a guideliner also available as a backup, but we didn't need it, fortunately. We post dilated the stent, and the final result was excellent. We can see that there was one more OM which was coming in below and had good flow even without the side branch flow was also preserved. So the cell design helps in preserving the side flow. It has an elastomeric drug. It is an elastomer drug-eluting stent. It has an excellent deliverability, and the radio opaque markers do definitely help. So in my practical experience, I found out that this stent has a very good flexibility and pushability. The radio opaque markers help in minimizing the radiation and helps in optimizing the stent placement without using excessive cines and stent boosts. It has a very similar handling to the current drug-eluting stents which we have on our shelves. And the initial apprehension was mitigated after doing a few cases. The stent was in fact superior in pushability and deliverability, and we look forward to using it in the future as well. Thank you.
Thank you, Dr. Anis. That was an excellent presentation, sweet and short, and you made everything quite clear about the stent. So, in acute,
some stomach pain complaint, I met the gastroenterologist.
yeah. So, just let me ask you, like I could see in such a high thrombus load, even in such a high thrombus load, you place the stent and the side branch was quite okay. It did not get closed. So it looks like the strut dimension is quite good in this stent, and it doesn't affect definitely. So that's one great point about this stent. So let me just ask the participants overall, like what is Dr. Manohar, what is the best part of this stent? We have all enumerated excellent points about this stent, but what is the best part you liked about this stent?
One is osteal placement. It's a excellent one. Second thing is no need for stent boost or stent enhancement for the post dilatation. Okay. And because of the stent marker, edge dissection easily we can avoid with this post dilatation. Third thing, but we must study how it is useful in primary PCI, because if there is a thrombus burden, is it thrombus will prolapse or thrombus reaccumulated in this stent? We must see it. In other stents like Onyx and other things, the tissue prolapse is comparatively lesser in that area. So now we must establish, is it true or not in this stent.
Okay, so those are excellent points actually, and
as well as this calcium modification, how it is useful, you must establish it. Because this expansion is less in this stent. So is it possible to expand more or not? If we are expanding it to the oversizing balloon, is it the stent fracture occurs or not? We must establish that one. These are all the things.
Okay. So you would recommend when choosing the stent to go directly 1:1.1?
Yeah, 1.1, 1.25. Like that.
Okay, that's a great point actually to add to the discussion, because most of the audiences over here would not have used so many stents. So excellent point to add to this discussion. And definitely, I would say that when we decrease the amount of stent boost, your radiation dose will come down like anything. So you protect yourself from radiation. That's another great point about the stent. Dr. Viveka, are you there? I think he has left. So does anybody else wants to add anything to the discussion? Because I can see some.
Dr. Sunil, are you there?
Dr. Sunil? I think most of the people have left the Dr. Sudarshan, I can see if you want to add something to the discussion. Okay.
Dr. Praveen, would you like to add something to the discussion or share any points?
No, I think the points are all well covered in the design of the stent and the cases also.
Okay. So
Hi, Dr. Amit. Sorry, I was muted. So no, it's an excellent. I mean, from the discussions that I've heard, it seems to be a nice stent. The trackability and the points of the markers where we can place the stent well. But we obviously, my experience with the stent is I don't have any experience, so maybe we use it in a few of our patients and then see the long-term data. But it looks very promising from whatever we've heard till now, and so let's see. As we use it more often, probably our comfort level with the stent would improve, and probably we'll get more data, and we use it in more complex. So what we have seen today is the stent being used in relatively straightforward lesions and not really very tortuous and calcific anatomy. So till we see all that and we see the trackability in those kinds of lesions and really tortuous ones, I mean, then we will probably. So it seems promising, but then we need to have that experience in those kind of lesions before we can really talk about. So I don't have any experience as yet because we don't have the stent in our lab, but it seems promising. So definitely, I think it would be good to use the stent.
Okay. Thank you so much for those beautiful comments on the stent. And I do feel that these are early days and we have all become comfortable with certain stents.
Yeah, absolutely.
Whenever we want to ask, the name automatically comes to our lips.
It just comes to us. Absolutely.
It just comes to our lips. So I think trying out these stents will definitely, increase our knowledge about different stent designs and how they perform. And in different anatomy, after we use in different anatomy, then only we'll come to know the basic, advantages of this stent. We still don't know about the stent fracture. We don't know about it expansion in the very calcified lesions because of. I agree with you that all the cases were straightforward, except a few cases that were osteal in nature, and in those cases, it was clearly shown that this stent has a great advantage. And of course, I could see that most of the operators were not using stent booster at all. So radiation protection is another great advantage for this stent. I think the third thing I felt was good about this was the trackability and the pushability. I should not tell about trackability, the pushability, because it has a nitinol lining on the top. The pushability should be really good. It will be better than other stents because the bending characters will not be there. It should just pass through. But of course, we should use more and more, and then only we'll come to know about the true advantage of these stents. And definitely, I would say that this new design that we are looking at, only after we do a couple of cases or a few hundred cases, then we'll come to know what is the real advantage of this new design. As Dr. Manoharan has clearly pointed out, I think we should be careful while we choose the size of the stent. And that's a great point to bring about, I think. So I think it was a great discussion. So all the participants, thank you so much. Thank you, Chairperson. Thank you, panelists. And I hope we all will be using these stents more and more. And in the future, this stent is going to take as a third stent on the lab, particularly, after the two big giants that's there in all the labs.
Yes.
Thank you so much.
Thank you. Thank you. Thank you.
Thank you so much, Dr. Amit, and thank you everyone. And just for the quick information that the dilation limits of the Lunipearl have also been updated. We have shared it in the chat box for your reference. So respecting everyone's time, thank you so much everyone for joining the session. Have a good night.
Thank you.
Good night. Take care. Bye-bye.
Thank you. Bye-bye. Bye. Good night.